All right, today we're diving into a really fascinating medical detective story. It's one where a single stubborn rash can actually be the very first clue to a rare hidden tumor. So let's get right into the investigation.
So, just imagine this for a second. You've got this skin condition, and it just will not go away. You've tried all the creams, you've seen the specialists, but nothing seems to work. Well, what if that rash wasn't about your skin at all? What if it was a signal coming from deep inside your body? That's the exact mystery we're going to unravel today.
Okay, so our story really starts with the most visible piece of the puzzle, a really particular kind of skin eruption. It's often the very first thing that brings a person to the doctor, and it's unlike almost any other rash out there.
So what exactly does this rash look like? Well, the medical jargon for it is a chronic, exfoliating erythematous lesion. Let's break that down. In simple terms, chronic means it's long-lasting. Exfoliating means it makes the skin peel, and erythematous just means it's red and inflamed. So we're not talking about a simple itch. This is a persistent, pretty troubling skin issue.
And this rash has a very specific and kind of intense name, necrolytic migratory erythema. The name itself actually gives us some big clues. Necrolytic points to skin breakdown, and migratory means it can actually move around the body, often showing up on the arms and legs. It also tends to come with other strange signs, like a smooth, shiny, almost unnaturally red tongue. These are the classic calling cards in the whole Glucagonoma puzzle.
But here's the thing. That rash, it's really just the tip of the iceberg. To find the real culprit, we've got to look way deeper. Because the problem isn't in the skin at all. It's actually hiding inside an organ we don't think about too often, the pancreas.
And the condition is called a glucagonoma. It's a rare kind of tumor that grows from what are called the alpha cells of the pancreas. These are the specific cells that are responsible for making a hormone called glucagon. Now, I know the word malignant can sound pretty scary, but a really key feature here is that these tumors are typically very, very slow growing.
So what does glucagon normally do in the body? Well, you can basically think of it as your body's emergency fuel release lever. When your blood sugar drops too low, your pancreas lets out some glucagon, which signals your liver, hey, we need you to release some stored sugar, stat. A glucagonoma is like having that lever stuck in the on position, just constantly flooding your body with way too much sugar.
And here's a really surprising fact about this. This rare condition has a very specific demographic it tends to affect. A staggering 80% of patients are female, and the average age when it shows up is right around 50 years old.
And this is absolutely crucial because having that fuel lever stuck on creates this huge domino effect. The constant high blood sugar, that leads to diabetes-like symptoms. The body gets tricked into thinking it needs to burn just massive amounts of energy, which causes significant weight loss. And this metabolic chaos can set off a whole cascade of other issues, like anemia and shockingly low levels of proteins and fats in the blood. So, with all these symptoms laid out, how in the world do doctors crack the case? Well, this is the investigation part of the story, where they start connecting the dots from that initial rash all the way to the hidden tumor.
You can think of the process kind of like a funnel. It starts out really wide, looking at those clinical symptoms we've been talking about, the rash, the weight loss. Then it narrows down to a very specific blood test. And finally, it zeroes in on the source with imaging.
And this right here, this is the smoking gun. A blood test is done to measure the level of glucagon. Now, in a healthy person, that level is under 200 picograms per milliliter, but in a patient with a glucagonoma, it's often over 1,000. That massive, massive difference is a definitive piece of evidence. There's no mistaking that.
So once that blood test confirms sky-high glucagon levels, the final step is to actually find the tumor itself. Doctors will use imaging techniques like CT scans and endoscopic ultrasounds to get a really clear picture of the pancreas and pinpoint the tumor's exact location.
And now for the final act, closing the case. Once a glucagonoma is found, what can be done about it? Well, fortunately, there are some very clear pathways to treatment.
The treatment strategy really boils down to one key question: has the tumor spread? If it's still localized, meaning it's just in the pancreas, surgery to remove it is the main treatment, and that can be completely curative. It can resolve all the symptoms. But if it has metastasized or spread, the focus then shifts to managing the disease with medication.
For metastatic disease, doctors have a whole toolkit of options. Chemotherapy can be used to help shrink the tumor. There are hormone-suppressing drugs, like octreotide, that directly tackle the problem by reducing glucagon production, which helps manage the symptoms. And then there are newer targeted therapies that can interfere directly with the cancer's specific growth pathways.
And here's the most important takeaway from all this, and it's a really hopeful one. Even when the tumor is malignant and is already spread, the prognosis is often surprisingly good. Because these tumors grow so incredibly slowly, a 15-year survival rate is common. That makes it a manageable, long-term condition for many, many patients.
You know, the story of glucagonoma is such a powerful reminder that sometimes the most unusual diseases can show up wearing the most common disguises. And it really leaves us with a final, fascinating question to think about. How many other rare conditions out there first appear with common, everyday symptoms, just waiting for the right detective to connect all the clues?